Um, Now, as I'm going to wrap up, we talk about these frequencies or these oscillations sort of as separate entities. It's important to recognize, and this is something the field, has really been exploring much more in the last 5 years or 10 years, that there's a lot of interactions between the frequencies. That is, they're not completely isolated events that sort of pop on and off by themselves, but that oscillations gate or constrain or sculpt or mold the other oscillations. And there's many examples of this. The upstate of slow oscillations, for example, is characterized by high frequency activity and often by spindles riding on top of it, whereas the downstate is quiescent and there isn't a lot of other oscillations. So there's a gating there. And gamma has been well recognized, particularly in animal models, but now in some human studies, to be phase coupled to theta across different regions. And there's an example of this that I'm showing from a paper from Tamura from a few years back. On the bottom of the screen are some relatively slow activity in the theta band and near the theta band. You can see above that, the gamma band is relatively phase locked, coming a bit after the peak of those theta waves. You get these little runs of gamma for 3 to 5 cycles or so on. So there's a clear phase relationship between these different oscillatory mechanisms. And that's very well recognized across many different relationships. Generally, though, the lower frequency is gating the upper frequency, or is affecting the upper frequency, is generally what's been shown. And this can occur at a location, or it could occur across locations. So it could be from one area to another. Often the hippocampal theta gating cortical gamma, for example, is one example that's often seen. The mechanisms for this that have been suggested are quite varied, and they're really not well understood or well proven. Exactly what are the cellular interactions and the network interactions that allow this to happen. And more evidence is coming out that shows that this coupling can be diminished or shifted or altered in various ways in many different disease states. In epilepsy, for example, we see that at the very beginning of seizures, there's often much greater coupling between theta frequency, for example, and spindle frequency, beta frequency, and gamma frequency, that suddenly the coupling goes up, at least in some seizures, some of the time. So there's, other interactions that are occurring under pathological states that are revealed by looking at these coupling mechanisms. And then finally, I've been talking about these frequencies as if they are a static entity. In fact, they are quite dynamic over development and over age. There's a progression of the different contributions of these oscillations during time. So this is work from Kat Chu from a number of years back, looking at different oscillations during sleep. And you can just see, looking at this spectral analysis on the left-hand side, and then broken out into different bands on the right-hand side, that at early development from birth to a few months, there's a very different spectral pattern than we see at a year or 2 years old, which is still quite different than we see when a kid starts getting into 8, 9, and 10 years old. The frequencies that are present and how robust they are changes over time. And this is true all the way across the age range. This is work from Haoshi's son and Brandon Westover's group, looking at many EEGs, thousands of EEGs across many different patients, and seeing these changes. Again, this happens to be from sleep. There's similar changes during wake. In the young years, there's a lot of low frequency activity and not as much high frequency activity. And then as time goes on, the high frequency activity comes to dominate a little bit more, and the low frequency activity is still quite present. And then as we get older, we start to see some more changes there as well. So these rhythms are not fixed. They're changing over the lifespan as well. And then finally, in the last couple of minutes, I'm going to very briefly talk about epilepsy. Epilepsy is sort of the canonical disease, although it's not a disease, which I'll get back to, for rhythms gone awry, right? It's like rhythms gone bad. Epilepsy has been recognized for thousands of years. The Egyptians, like many things, may have done the first reports of it. It's also been misunderstood for all of that time as being, possession and all sorts of other things that just aren't true. What it really is it's a state in which a patient has, or at least is at high risk for having, multiple seizures. From a practical point of view, we would define it clinically as a recurrent seizure risk greater than about 60%, really a person who's had 2 or more independent seizures or has a clear reason to have seizures. But it's really a symptom and not a disease. It is a situation in which there are these events that are characterized by abnormal oscillations, and those oscillations evolve in time and space. And there are many different frequencies that can be involved, really all of them. That during a seizure, you can get delta activity and gamma activity, and you can get them together and riding on top of each other. So all the frequencies that are present under normal circumstances are present during a seizure as well, or can be present during a seizure. Here's an example of one of the most typical seizures that people talk about and think about. This is a 3 Hertz spike wave activity in a patient who has generalized epilepsy. You can see these very large 3 per second events occurring here on the right side of the screen when the seizure started. That's sort of happening in a very consistent pattern, easily recognized on the EEG and have been studied for quite a while. The mechanisms of these things we think we have a pretty good understanding of, that it involves the thalamocortical loops and particular channels in those cells. Again, maybe not surprisingly, this is work that was worked out by Steriot and colleagues, where there's a particular sequence of events involving thalamic relay neurons and their discharge to cortical neurons, where there's T-type calcium channels that make a burst mode possible. That bursting then gives rise to the rhythmicity that we see in the 3 Hertz spike waves, and is the same mechanism essentially that's present during sleep oscillations. So the concept then is that this normal rhythm, in this particular case, the sleep slow wave, is co-opted or captured in a sense by us, an abnormal variant and tweaked in a way, and that's giving rise to the seizure in this particular case. So it's a normal mechanism that's been captured. Focal seizures, not generalized seizures, show even more variety and complexity with multiple rhythms. I'm just giving 2 examples here real quickly of seizures that start. It's on the bottom of the page here. A bunch of different rhythms that start, a bunch of different frequencies that builds up and it changes over time and space as well. It's another example, again, showing multiple frequency components during the course of a seizure, all of which could be found normally, but now are changed and modified and co-opted by this process. All right. So then in real summary that I'll run through quick so we can get to some more questions, hopefully. We see oscillations across the entire brain and across a full range of frequencies. There are generalizations that we can make about the oscillations. Slower is present when somebody is less awake. Slower is more widespread and more synchronous. Slower is longer and more continuous, less periodic. And that lower frequencies gate higher frequencies. Certainly the first of those 3 rules are honored in the breach. They are quite often broken. Gamma and ripples, for example, could be synchronized across wide areas of the brain, and slow waves and spindles could be highly focal, etc. As I talked about, there's lots of mixing and matching so that these rules don't fully apply. The mechanisms are very heterogeneous. They're ranging from oscillations that can be derived from a single neuron and the interplay of intrinsic currents to some coupling in small groups to cortical and thalamocortical networks. And as Akshay pointed out at the very beginning, the roles of different oscillations are still essentially all correlative. There's very little causative proof yet available. It's very difficult to do, but there's more and more work coming out that gets there or gets close to it or builds towards it. The presence or absence of these different frequency bands or oscillations can indicate pathology and dysfunction. And I just list a few of them here. As we see slowing in a whole range of different pathologies. We see too little gamma in those same pathologies, really. Lots of different frequencies in epilepsy. None of these are pathognomonic for a given disease or disease state, but they give you some hints as to what is happening and what the underlying pathophysiology might be, or at least what the consequences of that disease might be. And more we're turning toward thinking of them as targets. So there's a lot of work still going on, and it's still necessary for understanding the mechanisms at the single neuron, the population, and the network level, and getting to that causative question. And then really what we want to do is get to a full understanding of the mechanistic links between ultimately, normal oscillations and then pathology, how that changes or is resulting in a change in the oscillation and how that is impacting behavioral changes or symptoms. And then finally, we want to be able to do that so we can start manipulating these oscillations using neuromodulatory techniques to get back to the normal oscillation and block or change the abnormal oscillation and then restore normal function to patients suffering from a wide range of neurological problems. So I think this question. Jeff asks, do you have a sense for how degenerate the mapping is from activity neurons, particularly brain rhythms? Depending on exactly what you mean by this question, I think the mapping is certainly not very clearly one-to-one. That is to say, slightly different mechanisms can give you the same rhythm. Different neuronal subtypes can give you the same rhythm. And the same rhythm can actually be generated by different mechanisms as well. That is fairly clear, at least for a few examples. How widespread that is through the different frequency bands is not fully understood at this point. And part of the real challenge is figuring out when those different mechanisms do couple to those specific rhythms and whether it matters and why it matters. So there's a lot of interplay there that we still have to work out. Okay, right. So in aging, there's a question here about oscillation patterns during normal aging. So in normal healthy aging, there shouldn't be that much change. And in fact, one of the things that our group and in conjunction with Brandon Westover's group has started working on is that you could actually come up with a measure of, quote, brain age as distinct from chronological age based on the presence and absence of certain rhythms. And so you'll get octogenarians and nonagenarians whose EEGs look like, a 30-year-old. They have all the same rhythms, right? And then you'll get folks who don't. And so the idea there is that for normal aging, there hopefully or probably isn't much change in the rhythms. But if there is injury, and whether that's a neurodegenerative disorder or recurrent strokes or accumulated injuries for other reasons, then you get the sort of falling apart of these rhythms in some sense and a change in the EEG that way. And usually what you see is more slowing and decrease of the fast rhythms. The fast rhythms go away. So the rhythms, somebody asks about the rhythms, Dave Crowley asks about the rhythms detected in resting state MRI and the rhythms observed by EEG. This is there's a really complicated, long, multi-session answer to this. But the original sort of resting state fMRI studies that were done, we're looking at much slower interactions than anything we're looking at here, right? They're looking at bold signals on the order of seconds. That being said, there's now a lot more work where people are associating different rhythms, alpha rhythms and other rhythms, with particular resting states or particular functional networks and associating them that way. A lot of work still needs to be done in that area, but there are some links between oscillations at particular frequencies and how they're correlated over different space and underlying functional networks of different sorts that are detected by fMRI. So there are relationships there. They're sort of complicated and still being worked out. So Zamin asks about what's happening with gamma during AD and can 40 hertz delay AD progress? Well, the last question is a question that a number of people around here are actively exploring and forming companies around and so on, is can you use gamma to inhibit or at least alter Alzheimer's progression? Jury is still out. There's some nice data that says maybe, but a lot needs to be done to figure that out. And the idea there is you are restoring the lost function of that oscillation in some way or another. Whether that could actually delay progress, I think is really unclear whether that's the case. And Charles asks a related question right after that. Can it be therapeutically beneficial? Again, it's something that's right now in a trial phase, and I don't think we have a clear answer yet. So I don't want to come down one way or the other on that.